is given by Dr. Malik Hassan Mahmood, and the topic of presentation is platelet inhibition, anticoagulants, and thrombolytics. Here is the resource material. For the reference. Firstly, we will discuss case of a patient. Case 1. Mr. Asif was admitted to hospital for an emergency laparotomy for a perforated gut. He has a history of atrial fibrillation for which he is on long-term amiodarone 200 mg once daily. Following the laparotomy, he has new onset atrial fibrillation, which the medical team would like to treat pharmacologically. His only other current medication is thromboprophylaxis with enoxaparin 20 mg once daily. Questions are: what treatment plan would you initially suggest? What long-term monitoring would be appropriate for Mr. Asif? Here is the rationale. All patients presenting with AF, or atrial flutter, should undergo assessment of their risk of stroke. Although various risk stratification schemes exist, the CHADS-2 score is widely used. For Mr. Asif, the following is determined: congestive cardiac failure, hypertension, age greater than 75 years, diabetes mellitus. Stroke. Given Mr. Asif has a coronary artery disease, 2 score of 3. This suggests an annual stroke risk of 5.9% if no therapy is prescribed. This risk will reduce to 4.7% if he is prescribed aspirin, or 2.1% if he is prescribed warfarin. Assuming no contraindications or concerns, warfarin should be prescribed. In patients with stable vascular disease, such as those with no acute ischemic events or PCI/stent procedure in the preceding year, warfarin monotherapy should be used. Concomitant antiplatelet therapy should not be prescribed. Published data support the use of warfarin for secondary prevention in patients with coronary artery disease. Warfarin is at least as effective as aspirin. It should be noted that any combination of an antiplatelet agent with a vitamin K antagonist such as warfarin will significantly increase the risk of a major bleed. Our learning objectives are: platelet inhibitors, aspirin, ticlopidine, clopidogrel, abciximab, dipyridamole, anticoagulants, heparin, warfarin, lepirudin, argatroban, fondaparinux, thrombolytic agents, alteplase, streptokinase, anistrolase. With respect to their use, mechanism of action, pharmacokinetics and important adverse effects. Hemostasis, vasoconstriction, primary hemostatic plug formation, platelet adhesion and aggregation, fibrin clot formation, fibrinolysis-thrombosis, arterial thrombosis, adherence of platelets to arterial walls, white in color, associated with MI, stroke, and ischemia. Venous thrombosis develops in areas of stagnated blood flow, deep vein thrombosis, red in color, associated with congestive heart failure, cancer, surgery. Antithrombotic drugs are: aspirin is antiplatelet, heparin and warfarin are anticoagulant, streptokinase are thrombolytic. All of these prevent venous thrombosis. An overview of mechanism of action of antiplatelet drugs is given here. Mechanism of action and pharmacokinetic of aspirin, clopidogrel, abciximab, and dipyridamole is given here. Here are the uses and adverse effects of these drugs. Ticlopidine. Platelet inhibition is irreversible. Platelet aggregation inhibition is not significant until after approximately 4 days of regular dosing. Platelet function returns to normal within 1 to 2 weeks, as new platelets replace those affected by ticlopidine or clopidogrel. Clopidogrel selectively inhibits the binding of adenosine diphosphate, ADP, to its platelet receptor, and the subsequent ADP-mediated activation of the glycoprotein GPIIB/3A complex, thereby inhibiting platelet aggregation. Biotransformation of clopidogrel is necessary to produce inhibition of platelet aggregation, but an active metabolite responsible for the activity of the drug has not been isolated. Clopidogrel also inhibits platelet aggregation induced by agonists other than ADP by blocking the amplification of platelet activation by released ADP. Clopidogrel does not inhibit phosphodiesterase activity. Clopidogrel inhibits the ADP P2Y12, P2-TAC, platelet receptor. Acts by irreversibly modifying the platelet ADP receptor. Consequently, platelets exposed to clopidogrel are affected for the remainder of their lifespan. ADP-induced activation of the platelet P2Y12 results in the activation of the GPIIB/3A fibrinogen receptor. Dose-dependent inhibition of platelet aggregation can be seen 2 hours after single oral doses. Repeated doses of 75 mg per day inhibit ADP-induced platelet aggregation on the first day, and inhibition reaches steady state between day 3 and day 7. Platelet aggregation and bleeding time gradually return to baseline values after treatment is discontinued, generally in about 5 days. Indications for clopidogrel: recent MI, recent stroke, or established peripheral arterial disease. For patients with a history of recent myocardial infarction, MI, recent stroke, or established peripheral arterial disease, acute coronary syndrome. For patients with acute coronary syndrome, unstable angina/non-Q wave MI, including patients who are to be managed medically and those who are to be managed with percutaneous coronary intervention, with or without stent, or CABG. Clopidogrel for patients with acute coronary syndrome. Unstable angina/non-Q wave MI, clopidogrel should be initiated with a single 300 mg loading dose and then continued at 75 mg once daily. Aspirin, 75 mg 325 mg once daily, should be initiated and continued in combination with clopidogrel. Most patients with acute coronary syndrome also receive heparin acutely. Platelet activation, arterial thrombus formation is illustrated here. Anticoagulants, oral anticoagulants. Warfarin, injectable anticoagulants, indirect thrombin inhibitors. Heparin, UFH, fondaparinux, direct thrombin inhibitors, lepirudin. Argatrobin. Warfarin normally, Vitaminc, is converted to Vitaminc epoxide in the liver. Rightward arrow. This epoxide is then reduced by the enzyme epoxide reductase. Rightward arrow. The reduced form of vitamin K epoxide is necessary for the synthesis of many coagulation factors, 2, 7, 9, and X, as well as protein C and protein S. Rightward arrow. Warfarin inhibits the enzyme epoxide reductase in the liver, thereby inhibiting coagulation. Heparin. Heparin UFH inactivate factor IIA through formation of a tertiary complex. UFH binds more to plasma proteins, endothelium, and macrophages. Reduced bioavailability and greater patient variability to a given dose. UFH inactivates factors IIA and XA and affects the APTT, measure of anti-factor IIA activity. Exogenously administered antithrombotics are alteplase TPA, recombinant form of human tissue type plasminogen. Activator, streptokinase, protein extracted from beta-hemolytic streptococci that acts like plasminogen activator. Anistroclase, a prodrug, streptokinase. In a non-covalent 1:1 complex with purified human plasminogen, acylated at its active site to keep it inert. Here is the comparison of streptokinase, anistroclase, alteplase. Their mechanism of action, fibrin specificity, efficiency. For clot lysis, nature of drug, indications, route of administration, half-life. Metabolism, potential antigenicity, cost, and adverse effects are discussed here. Thank you.